So during COVID-19, more than 3,000 AI models were developed and published to help clinicians take care of patients. Anybody want to guess how many of these models were actually used in hospitals and in clinics? Actually, less than 30. So less than 1% of these models were actually used. Now, this is not a story about AI failure. This is about the gap that currently exists between what we can develop as AI technologies and what we can actually scale in healthcare. Next slide. So I'll tell you about our failure, our wake-up call during COVID. We're in New York. We're at Northwell Health, the largest health system in New York and one of the largest in the country. So during the first wave of COVID, we had already by April of 2020, thousands of patients that were hospitalized. So we had all their data. We developed an AI model to actually predict their deterioration. And the model was working great. It was 95% accuracy, so we deployed it across our hospitals. Very soon, 2 to 3 months later, we started noticing that our clinicians were kind of disregarding some of our alerts and our suggestions. So we started looking at why, and what we noticed was that the model was trained on data from first wave, which was high mortality, and it was overestimating the probability of deterioration. So it was flagging essentially patients that were perfectly stable. During these months, many things changed. Our physicians started treating more efficiently these patients. Patients that wouldn't leave their house in March of 2020 started showing up in our hospitals much earlier in the disease progression, so we could treat them a lot better. So these changes were completely oblivious to our AI algorithm. So what we've learned from this is that the difference between a research algorithm and what you can deploy in a clinic is this gap, and the fact that the understanding that healthcare and healthcare data are messy. It's a high stakes environment and very dynamic environment where a true positive today can become a false positive tomorrow. And that false positive doesn't just affect your accuracy metrics, it actually affects trust with your clinicians. So I've been in this gap for the past 5 years. And we're developing models in the lab, and then we're deploying them across our hospitals. So I'll tell you what we think works and what we saw works. We used first start with the real problem. So we went and asked our patients, what is your complaint? And number one on that list is that you don't let us sleep at the hospital. Every night at 3 or 4 a.m., a nurse comes in, measures blood pressure, measures temperature, wakes you up, and that's not good. And the nurses actually don't like it. So we developed an algorithm that can actually identify patients that are perfectly fine, perfectly stable, so nurses don't actually wake them up. Now, this algorithm can avoid more than 50% of overnight sleep interruptions by remaining perfectly safe. Next slide. Another thing we did is we asked our nurses, how can we help build some technology that can help you? So across the country, there is a huge problem in nurse shortages. Nurses quit their jobs, and the ones that are left behind have to work more, have to do more overtime, increase their burnout, and that creates that vicious cycle. So when a nurse leaves, it takes months to a year to actually find a replacement. During that time, we have to have nurses, so we use the solution that we hire flex or temporary staff. Temporary staff are double the cost of a regular full-time nurse, and they also disrupt workflows. So what we built is an algorithm that can actually forecast not only how many nurses we're going to need in a year, how many nurses are going to leave, but also what are the reasons that they are leaving for. So we can preemptively hire nurses, but also modify our retention strategies at the health system. And when we tested that to identify what could be the cost savings, next slide, we found that only in 10 out of like more than 500 units, we could have an ROI of close to $10 million. So there's substantial ROI within our health system every year using these types of strategies. So these problems are not sexy AI applications. We didn't cure cancer with AI. But what we did was solve very important workflow problems that have an impact on time and on ROI for our hospitals. And so there's always money in the banana stand, as I tell a lot of my next slide and last slide. So finally, I'm going to end with trust. You need, in order for the doctors to maintain using your tools, you need to keep their trust. And how you do that? Well, you don't explain to them the hyperparameters of your deep learning model or the architecture. They don't care about that. What they care about is why you're saying what you're saying. And also, what can they do about it? Give them actionable insights. So we built an in-house iteration algorithm, and we've rebuilt it because in the beginning it was just flagging high-risk patients, and now it actually gives more information and actionable information on the clinician on what to do, what's modifiable, what they need to pay attention to in this patient. And by doing that, we engage them a lot more. So that's it. And I don't know, I'm a bit over time, but thank you so much.